Welcome to the Drug Medi-Cal Program Certification, Preparing for Certification under the 1115 Waiver webinar, presented by the California Institute for Behavioral Health Solutions and the California Department of Healthcare Services. I now turn it over to Dr. Will Mariscal.
So good morning, everyone. We're continuing on our series of webinars and the regional meetings that we've had to help support us all get ready for the waiver. And today's focus of this webinar is going to be on provider credentialing or re-credentialing. And I'd like to introduce to you Jan Tice, who's our presenter for today. He's currently a consultant with CIBHS, and he provides training and technical assistance for mental health and substance use disorders programs throughout California. So some of you might already have had an opportunity to work with Jan. He is also an adjunct professor in the Psychology and Human Services Department at Cabrillo College and California State University East Bay, and has over 28 years of experience in the mental health field, including work in child welfare, psychiatric hospitals, health and wellness research, substance abuse treatment, and county administration. With that, I'd like to welcome Jan. And Jan Tice, thank you for being our presenter today and presenting this important information.
Thanks for having me. Welcome, everyone. So good morning, and I'm going to dive right into our topic of the Drug Medi-Cal waiver information. Kind of really start off just very briefly to really kind of say that the demonstration waivers traditionally have been this really good vehicle that states have had to make innovative changes in Medicaid programs, and those have been, programmatic service. And a big piece of this, though, I'm sure it'll creep into the talk today about financing, because it's a powerful tool for drawing down some Medicare, Medicaid monies for services that traditionally wouldn't be available. So we're using this innovative tool, and primarily, while the waiver is larger than just Drug Medi-Cal, in the Drug Medi-Cal section, where I'm going to advance the slide here. Oh, I thought I could, and I don't know if you can advance the slides. All of a sudden, my system right here isn't allowing me to advance slides.
Jan, just re-click on the screen again with your mouse. There.
Okay. There we go. I clicked too far. I wonder if I can. We're going to find my technical thing.
Use your keyboard. There you go.
as I take you a little bit too far. I'm used to not using the mouse, but going with just now. We'll get to goals of Drug Medi-Cal, and some of these in the Drug Medi-Cal organized delivery system. There is enabling and looking at more local control and accountability. Of course, this is really local control coming to the counties. Greater administrative oversight. This is, of course, really, I think, focused at looking at reducing waste, reducing redundancy of services, reducing certainly fraud in any cases where we may be concerned about that, and the efficient use of these resources. In this, it's somewhat of a decentralization down to the provider level. And to the county level. It is specific to decentralizing or slowing down some of the credentialing and selection of programs to the counties. Counties need to write selection policies and procedures. In the 1115 waiver, this is fairly clear that you cannot discriminate for the type of entity, and that's a for-profit, non-profit, sole proprietor, or the risk level of clients they serve. And these may be some high-risk NTPs, NCPs. You can't limit anyone that serves somebody who's a high user of high-cost services, say criminal justice, nor can the selection processes, policies, and procedures discriminate against reimbursement or the indemnification of any provider. I'm going to try and keep this mouse off the screen. Other things that need to be considered is providing services, selecting providers. Your contract that's developed must include that the providers provide services which are consistent with the 6 quality aims of the IOM, the Institute of Medicine. And those are pretty just general. It's in the waiver that the care is safe, it's effective, it's patient-centered, timely, efficient, and fair or equitable. So, ensuring that providers not only hold to those principles in terms of what they say, but they also deliver. And I think one of the big ones that I'm going to look at and that would be considered when you're reviewing and looking at your providers would be especially the one about patient-centered and probably timely and efficient, because that does look at the provision of services, especially treatment plans, delivered services that are patient-centered, individualized. This has been an issue that comes up in monitoring reviews. And timely and efficient, that access to service happens quickly and efficiently. So I know that when you look at how you select providers, you look at those requirements. It's not only in their mission statements, what they say, but also actually can their systems deliver this? Do they maintain a safe facility? Do they keep records in compliance? These also align with AOD standards, drug Medi-Cal standards, so that if there's some redundancy there. A new one that is going to be quite a change is trained in, and I put in there, and use ASAM criteria. So certainly in the waiver, there's information about that there will be trainings, and regional trainings are happening right now in the introduction to, I would say, the ASAM criteria, but the conversion for many agencies, county and then provider level, into using the ASAM, not just as a placement criteria, but as their primary assessment tool, replacing possibly ASI and any biopsychosocials, is going to be a process of making sure as a county that you're highly involved in that, and with your providers in that conversion is going to be important. Meeting county quality assurance standards. You may already have quality assurance standards, but making sure those standards from the county and to the provider are aligned with drug Medi-Cal and waiver principles, and provide appropriate supervision of staff is a key thing. And additionally, all drug Medi-Cal programs need to be certified. The waiver is really requiring counties to provide at minimum the following services. And this is right again out of the waiver language. Outpatient, your outpatient ODF, intensive outpatient. You have an option of partial hospitalization, but definitely outpatient and IOP. Residential, at least one level of care. When you go look in the waiver, there are a number of levels of care. If you have added levels of care, that's fine, but you must provide at least one level of care as described. Again, aligning with ASAM definitions of intensities of levels of care, provide one. Withdrawal management, again, at least one level of care. Medical assisted treatment, it's required, and actually what's required, again, you have the OTP benefits of methadone and buprenorphine. They also talk about treatment, TAR, naltrexone, and the extended naltrexone, acamprosate, and naloxone. So these all come into the medically assisted treatment, and it's a requirement in terms of having a provider for it. Recovery services are also required. This is kind of a new area in many ways, an expanded benefit, looking at having recovery maintenance services, which extend out of the traditional shell of a recovery facility. It may be telephone monitoring, telehealth will be approved, outreach, family types of support groups. So this is some work that's been in the works since 2010-11 with White, McClellan, and others looking at continuous recovery models. And it's fairly exciting that this is being brought in, and it's a requirement. Case management is also included, and case management is not really clearly defined in terms of is it assertive case management, community-based, how does it model? The principle behind this is ensuring the persons or beneficiaries of this model do move through the continuum of care. We're looking at a continuum of care. The case management needs to at least address ensuring that beneficiaries move through this continuum of care. And physician consult isn't optional. These are the services that need to be not only brought into, but certain ones of them certified.
Jan?
Yes.
You already have a few questions. I know you were just doing an overview, but some folks are already, it's already triggered some questions. So
sure.
I'd like to read them to you. So I have one about selective provider process. Does it have to be through an RFP, or can the county choose a selective process such as RFI, RFQ, et cetera?
Okay. The 1115 waiver, and none of the, I've read over all of the notes from the stakeholders meetings with DHCS, and there seems to be the biggest concern that's come up is that whatever the process is, whether it's through an RFP or any other mechanism the county decides, that it's open and fair and equitable and doesn't discriminate. So DHCS doesn't seem to be interested right now at this point in micromanaging the process and whether you do it through an RFP. So that would seem to be fine. Open panels, but whatever process works best and seems to be at least meets that requirement for not being discriminatory. So if somehow the process were difficult, made it difficult for someone to come in and get on a panel, that might be looked at as discriminatory.
Okay, and then I have one. There was a comment someone said, we still use paper charts currently, and we don't know how long we have to hold on to AOD files and charts for minors and adults, and that was a question mark.
Well, the hold on to, there's some interesting parts with a waiver, where if you look at Title 22 requirements, there seems to be, well, somewhat of a conflict, or at least a difference in certain parts that the waiver addresses, and Title 22 says, no, do it a different way. I think what's going to happen, what's traditional with other states that have done a waiver, where there's some difference between a waiver requirement or a waiver standard and, let's say, another standard that in ours, Title 22 or Title 9, the waiver seems to take some precedence because it's a direct contract with DMS. There's, in terms of how long you hold a record, what's going to be the standard right now that's not changed by the waiver in terms of paper is whatever drug Medi-Cal or Title 22 says. So it would be that 3 to 4 years, and that would not change.
Okay. I've got another one. Are there tools available to ensure facility safety and minimum standards?
You know, actually there are. Certainly one of the things, I mean, I do some technical assistance consulting, and it's something I would be willing to share. DHCS has traditionally done a site visit. I will talk about this a little bit later in the presentation, but DHCS has traditionally done site visits. You know, certainly for licensing. I'm going to talk about the AOD side, the alcohol and other drug licensing and certification of programs on the non-drug Medi-Cal side. Well, the state at least it looks like right now, that'll stay with DHCS. So you may get some programs, let's say like if it's a residential program, it's going to be required to be licensed, required to be certified also on the AOD side, and then get its drug Medi-Cal certification, which will happen as a collaborative with county and state. When they do those walkthroughs, part of that walkthrough is a safety check. So I have a safety check. Yeah, there's a safety checklist. If somebody doesn't have one, I have one. How I would get that to them? Yes, they could request it through TA, or maybe we can talk about how we could post that up. But there is a safety checklist that's been used by Department of Healthcare Services, let's say, for their licensing and for their certification of outpatient drug-free IOP programs. And I think that's a good tool. You know, it's basically, I would say basically, in a summary, walk it through as, gee, does it look like the facility's clean? You know, has the fire inspection done? Are they in conformity with that? Are the carpets torn up? You know, is there, that's the nuts and bolts of the checklist, but it also looks at ADA accessibility, probably not to the degree that somebody who's an ADA person coming in and measuring everything, but I have an ADA checklist which really talks about our doors wide enough, you know, and how do they open. So there are checklists, yes, and I highly advise that anyone at a county that doesn't have some just basic checklist for what's a safe, accessible facility, request a TA from CIVHS, and we can deliver at least not the DHCS approved tool, but what's the standards that's been used in the state and at the federal level. Good. It's probably a hallmark. If you don't have tools, you're going to need some basic tools.
The questions have been adding up, so I don't know if we can try to give more concise answers, and I might have to hold off on some questions so you can continue, and we'll get back to those questions later. But let's try a few more. When's the anticipated date of the waiver to begin?
No date yet. They're still talking to CMS about it, even getting, we're kind of like past the date when it would have expired, and we're sure it's going to continue. But 6 months is a good line. Much of the financials still working on. So,
and I think the key thing, if I may add, Jen, is for listeners to understand is that this is optional by county, and so counties are going to choose to opt in. So this might not happen in a county that you're in if your county does not choose to opt in.
Absolutely.
And then there's a recommended phasing that DHCS has of starting with the Bay Area counties and I think next Southern California, and I forget what the sequence is. But so that's important to keep in mind as well.
Absolutely.
Okay. Another one is about will buprenorphine be covered without a TAR?
Excuse me?
Another one is, will buprenorphine be covered without a TAR?
Actually, buprenorphine in the waiver is not TAR. It's over on the side that it needs to be provided in an OTP.
Great. And then I think I'm going to hold off there so you can continue, and we'll go back to questions.
So counties have this rolling credentialing, and consistent with federal requirements, counties are responsible for issuing, when I say the drug Medi-Cal certification, it's really a provisional. Application forms, well, they will remain under DHCS for the development. I put on my slide here, no change yet, but there are new draft forms. Meaning from 12-14, there's a new draft drug Medi-Cal application 6001. It is on the DHCS website. They did a webinar about it. It's worth looking at. Actually, the good news is it's easier than the old one. So it makes some of the process of reviewing the form itself easier on the counties. With the application of the process, yeah, there's a change from PED centralized application processing to a county, and that's Provider Enrollment Division collaborative process. Counties will use the DHCS forms, but you'll have your own procedures for these selections. Again, do you do a panel? Do you just ask for people to come in? Do you do a formal RFP? That's really going to be up to the counties. But the forms you use, that's not. So the county's responsibility for processing these applications, again, how do you take them in? How do you process and review them? The criteria for accepting and rejecting, I would really strongly, the DHCS has application and I have application guidelines. So following those, how you select providers and your policies and procedures about that, counties, you get to do that. But in terms of the certification, aligning with what DHCS does and being the frontline reviewer with fidelity to the requirements of the application is not a variable that counties can do. So you have the initial application form, that's going to be on the county's box. Reviewing the provider agreement at Form 6009, that's going to be in the box. You'll see a part down there that has the no sign across it, and that's a drug Medi-Cal protocol. I don't know if some counties, anybody's had to deal with the protocol. It was a part of the 6001 application where providers had to include some of their policies and procedures in terms of the administration and the program management that demonstrated that their program was aligning with AOD standards and the drug Medi-Cal standards. That's always was a big part to review in terms of just getting the application. That's not on this new draft application, the 1214 revision. That makes application review a little easier. The drug Medi-Cal disclosure statement, and that would be the 6207 or the 6010 if they need to do with that is not required for states to review. That will still go to DH for review. So the drug Medi-Cal application 6001 and the 6009, that's what counties will have a process where they'll review it. My little thing down there, I need help, will really be an indicator that frequently providers need help and assistance with completing these. It's going to be probably the process that the county can adopt with how much technical assistance would they give providers, if any at all. So that's totally an option. It's also the county's responsibility to conduct the initial on-site facility review. Now, this is where, while you're not needing to do a large policy and procedure protocol review against drug Medi-Cal standards or alcohol and drug standards, when you do the on-site review, I would say that's highly, highly recommended. Because one of the, again, while this is a decentralization, certainly one of the elements that's being looked at is how do we get quality providers that would not be reviewed at moderate to high risk levels. Moderate to high risk levels are, there's a release that's been put out for that. I'll try and give you a reference. It's a Risk Bulletin 8714 with DHCS, where it talks about limited, moderate, and high risk facilities. Those are generally facilities that may be at risk of waste, fraud, or some abuse to the drug Medi-Cal program. Frequently that comes from agencies that have poor compliance in the administrative, general management, or program management with Title 22, with drug Medi-Cal standards, with AOD standards. So if a county does not have, I would say, a good review checklist that facilitates I'm going to say a quick, efficient, but effective review that, interestingly enough, will also be used probably as your monitoring tool for periodic reviews of the programs themselves, then this is an area of technical assistance I would recommend right now to be able to develop this tool. So you can, again, go to agencies and say, are you in compliance with these, again, these three: AOD standards, drug Medi-Cal standards, and Title 22 as it stands and with some modifications from the waiver. You'll also conduct this facility review, and that's, again, looking at cleanliness, safety, and accessibility. I don't know if there's any giant questions you want to go to right now, Will. This is a pretty good place.
Okay, let's see. Yes, we do have a bunch of questions. So the next one are, with revisions of standards such as ASAM versus biopsychosocial assessments, will counties be required to allow for Joint Commission mandated standards to be incorporated in provider policies and procedures? ASAM is too limited for use by Joint Commission accredited provider.
Well, that's a huge question. Joint Commission, and of course, if I go back, generally Joint Commission accredited providers are traditionally in the, I'm going to say, private, or also in the private sector and the public sector, and they're involved with many managed care companies, and it's the highest level, at least, we have of accreditation. If an agency who's JCO has to meet those standards, but in terms of using, if you're going to have to do, you will have to use ASAM as an assessment. You will have to use, if you're going to participate also in the waiver, how that integrates with your current assessments, the tools you use, and the systems you use to meet your JCO standards. You're going to have to find a way to also, either if it's duplicative, it'll have to be duplicative, but you're also going to have to use those ASAM and demonstrate that in your charts and in your reporting and your monitoring points with the county. Quality assurance and utilization review. There won't be a flexibility on that. I don't know if that directly addressed the question enough, but as I understood it.
Okay. Well, I invite the questioner to add additional question, and we'll get back to it later on as we get through the list if they want additional follow-up. So let's move on. We have, can you apply for the services separately, or will it need to accompany ODF, IOP, residential services?
Well, the application right now, as it stands, it'll follow the rules of the application. If you're wanting to certify an outpatient program, probably have a separate certification application than you would for if you also have a residential. So it'll follow the rules of just how drug Medi-Cal does it right now. In terms of whether you want to take that individual on it as a provider, it'll follow, and this is it'll follow the standards that the county certainly puts out for what are the standards in their process. So as long as the agency meets whatever those standards are, and I'm going to admit I'd be head scratching to say what are my standards I'm going to have, but it puts them together, and it's possible that I can say it's possible that maybe an agency you'd say, no, in some accessibility or in some manner, no, not your residential, but yes, your outpatient. They generally won't be lumped all together. And of course, when you go for the certification, you've got to fill out a separate certification for the different programs you want to certify. Because you're certifying, especially if there are different addresses.
There was a follow-up question by the same questioner that was like, just getting a little more specific, I guess, but could you apply for case management or recovery services separately? I think you're addressing.
Well, yes, that's a service you're going to do, and let's say that would be under an outpatient. It'd be an outpatient service, but it'd be a service you would provide under. Let's say I'm going to do outpatient, and I'm going to do recovery management services. So I would be certifying an outpatient, and then the specific options I would be providing in that may be the outpatient counseling. I may also say I'm going to do recovery services. Some may say we're going to do outpatient, but I'm not going to do recovery services. That'll be a part of the application. The incumbent part upon the county will be that they have an adequate array of providers that will provide all of these services that are required so that it ensures accessibility. That's going to be the bigger fit. So when a county say we're selecting providers, counties are also going to be looking at, well, the provider itself, and does it fit into the requirements that I have for a quality provider, and do they look like they could become drug, or are they drug Medi-Cal certified? But also the county's got to have the view of the bigger picture of their landscape of what services are required of me as a waiver county. And not only am I providing those, but do I have enough, a depth, let's say, on my bench to be able to provide all of these services. There's some language in the waiver, and it's been discussed about how about smaller counties that want to opt in, but maybe don't have a deep bench, or they have some of the services that are required that they don't have providers for. Let's say if I don't have a residential in my county. You can, if you have a neighboring county, and you can work out some contract arrangements, farm that out. But that's going to really, I really want anybody considering that to do a lot of discussion up with DHCS about how you would arrange that in your plan that you're going to propose to become a waivered county.
Okay, there are two case management questions that I'll try to read together, although you could answer them separately. And then there are about 2 or 3 questions around the physician consult that I'll try to read together too, so we can get through some of these that are similar topics. So the first set of case management is going to be, I was told at provider meeting that there isn't case management yet. Is this to be true or not? And then the next one is, are there going to end up being minimum standards for case management, i.e. linkage to PCP, housing, et cetera, or is it going to just be defined by the specific county? So 2 questions around case management.
Well, what they're saying right now is that the counties and the responsibility will not necessarily be provide, but at least coordinate case management services. And it could be at county sites, county locations. The counties will be responsible for determining which entity or who monitors case management activities. Again, the case management activities, they haven't defined exactly how, in a limiting way or an expansive way, it's left open to how aggressive they can be or where they're cited. But certainly counties are coordinating this system of case management, which ensures that people move through this continuum of care. They assist people in getting many of these, not only through the system of care, but get many of these recovery services, which may be linkages to employment, linkages to housing, necessary things to support their recovery. And they focus on this coordination of the substance use care. So case management in terms of the standards for it, because it hasn't maybe, say, been defined in a very clear way, again, and how assertive it is, or let's say even the qualifications. I've seen the qualifications yet about who can, the case management only be done by a licensed person. Could it only be done by somebody who's a social work background? Who this has been discussed in the stakeholders meeting, but there hasn't been a clear response to that. There's not case management standards literally in the titles or in the drug Medi-Cal standards right now. So it's an open area that I guess if I were looking at how would I as a county define my case management, I would go to more social work. What are the standards of practice right now? When we don't have in some of these areas a clear defined drug Medi-Cal standard to go to, we have other areas where I could think we can look real quickly at what might be viable models, what are best practices in the industry. If I go into case management that may be over on the mental health side, and what are the requirements, all I have to do is look in that room right there and say, that's probably going to be a real good vision for what we're going to see in drug Medi-Cal case management. So while DHCS hasn't specifically said it, I think we have some good models to look at.
Okay, we'll get to the questions on physician consult. I think both of the questions are essentially getting at the same angle. They want to know, but I think it'll be helpful if you do the first part of one of the questions, which is, can you clarify what is meant by physician consult being optional? Because what the rest of the questions are is they're wanting to know what that means in terms of the requirement of having a medical doctor on staff or as a director. So I think it's really important to define the physician consult that is being talked about in the waiver, because I think people are getting it confused with this question about the requirement of a medical doctor on staff or as a director.
Right. Well, let me kind of do it from the first part, which is around what is required, from the physician in terms of the waiver. And very clearly in the waiver, beneficiaries will be qualified in terms of their qualification for being a Medi-Cal beneficiary. And also they say we'll get an initial screening and diagnosis for substance use disorder that would be done by physician or an licensed person. And once they receive this, and this is every 6 months, and then it's renewed. So I've had a question, and I haven't got a clear answer on that from DHCS. Does that mean that programs then, when somebody comes in for a mission, don't have to do the rigor of the Title 22 of, let's say, establishing medical necessity? Because essentially there's going to be this initial qualification, and again, it has to be a face-to-face or telephone consult with a physician, or as it's saying in there, it could be a LCSW or an MFT, somebody who's a licensed person, to establish this diagnosis and those medical necessity, which is they have an impairment that requires treatment. The program will have to evaluate level of care, but there's a question about, when they come to the program, do they also, again, have to see a physician? I got to really tell you that's a conflict, again, with the 1115 waiver, or at least not necessarily a conflict. It looks like it's a little different procedure than what we've been told under the drug Medi-Cal standards in Title 22. Programs to qualify to be a certified program must have a medical director, and that's not taken away by the waiver. And the medical director's duties are pretty well identified under Title 22, and again, the drug Medi-Cal standards. That isn't taken away from the waiver. So you hold programs accountable and keep them with that. What may change with the waiver is, again, this establishing medical necessity and when they see the physician. You may get the variance to the waiver with that in terms of these telephone consults. What does that mean in terms of this requirement for a physician consult? They're not talking about the submission or evaluation for the medical necessity to admit into a program. What they're talking about with physician consults, it's more outside of the NTP, which frequently in an NTP somebody may go and get evaluated for various medical things associated with their dosing or complications they're having. This is really talking about additional physician consults for anything that's let's say complicating their recovery. It's not necessarily direct physical care, but it's consults about, oh, let's say I'm having some challenges with my management. I'm doing naloxone, or I'm doing Vivitrol, and I need a physician consult about whether I'm want to continue with that, or how it's affecting my waking. These are just an optional consult that may be paid for or a required service that we provide. Actually, what they've said is any physician consult that's outside of that admission establishing medical necessity for programs that are not NTPs is an option. You can provide that and have it as a service for people, or you can have it still rest over in primary care and then try through case management to get people linkage to primary care. So physician consults, that's pretty much the explanation they've given.
Yeah, and I've heard it simplified, said simply, this is for general physicians to get consultation around substance use issues. That's what it's talking about. It's not for the client to consult a physician. It's not for a program to consult a physician. It's for physicians to consult for substance use expertise.
Right. Or anything that would be consulted. Yeah, but some people have looked at it with that. I can consult with my physician, and it's not that.
No, right. And then maybe you want to go on. I mean, there's still a few more questions, but there's one that's related to physicians. It's could you repeat services that would fall into medically assisted treatment? So maybe you want to take that one and then continue.
Well, certainly the medical necessity issue. It stays much as it has been. Medical necessity must be established, and whether you can, counties will have an option also to do like excuse me, my phone just clicked. Okay, so I want to make sure I was still on the line with you. But medical necessity is still established at intake, and there's a question about whether it can be established, let's say, through a central intake, and the new waiver standards say it's got to be every 6 months. So it seems like by the waiver, when a beneficiary is recognized as needing this drug Medi-Cal program, the DMC-ODS services, that they will get evaluated by a physician. As by the waiver can be over the phone or face-to-face. So that right now changes what the drug Medi-Cal read, well, Title 22 now, as it was the emergency reg said, that the physician evaluating the patient didn't need to be a face-to-face. This is being amended to it needs to be either a face-to-face or a telehealth over the phone interview. It establishes the medical necessity, which is not only the DSM diagnosis, but impairment and an impairment that would benefit from treatment. And once this is established, it seems like the person is then a candidate to access the service array that's in the county for the drug Medi-Cal. The question would be, and it gets updated every 6 months, which is consistent with continuing stage justifications.
Okay.
Programs that are in the array will still need a medical director. Now, the question will be, will they access for their medical necessity that initial that's done with the physician, again, that may be centralized, or can the counties say that that's still going to rest as a requirement of the programs to provide those every 6 month justifications? And if one program, let's say if I go to program A and I get admitted and the medical director there establishes medical necessity, and I discharge that program and I require an outpatient program and I go to program B, can we leverage that intake of that medical necessity? That's a great question that's been posed, and it has not been answered. Actually, it would be real efficient if that could happen one time every 6 months, and there could be a pooling of the resource of establishing medical necessity. But each program will still, just by certification standard, be required to have a medical director. I'm sorry that's kind of squishy right now, but again, it's an interesting change in language in the 1115 waiver about how they're saying to establish this every 6 month diagnosis and medical necessity, and how that dovetails in with current Title 22 standards. DHCS has not articulated how they want those two to fit together real smoothly.
Okay, Jan, let's go ahead. We'll get to the other questions later. And also, some questions we just won't have time for. If we don't, we'll be able to follow up with answers by email.
Yeah, we have about 40 minutes, and there's not that many more slides. I think we'll be able to certainly at least bring up some good questions. I hate that some of them don't have exactly real clear answers right now, but I think sometimes being able to articulate the questions and notice these are the ones you still want to bring to. There are going to be more stakeholders meetings and get better definition. That would be important.
Okay, great. Well, then maybe I'll wait until you finish the presentation, and then we'll address all the remaining questions that we can in the time that we have left.
Okay. So the county will make a certification recommendation to DHCS. Your process is, again, selection, some way of selecting or inviting providers in. Every provider must be drug Medi-Cal certified. So if they aren't certified or they require recertification, it's going to be the county's role to do that initial application process, again, with the exception of the drug Medi-Cal. Well, you'll do the initial 6001, but the disclosure statement will go to DHCS. Once it's reviewed, you'll make a recommendation and issue provisional certification. By the 1115 waiver, programs will be able to start operating and billing with a provisional certification. If I were to make a recommendation over a county right now, I would certainly want to ensure that I want to be pretty sure I've got a program that's going to be, I'm going to say, not at a real high risk. There has not been a statement about if in fact you provisionally certify a program and they start billing, and then DHCS says, we looked over their Medi-Cal disclosure and we're not sure we're going to support this. What happens to the billing? That's still a question. So there's a risk liability area there. And I don't know you're going to get a good answer for that except to do your selection process very, very consciously and with good fidelity to what the standards are. DHCS will review the county recommendations. They will review and approve the drug Medi-Cal disclosure statement, and then they will provide certification, the final. They'll also certify any county-operated drug Medi-Cal programs. So final certification decisions still rest with PED, but they do say in there they do want counties to, once they've done a provisional certification and they feel confident and the competency and the fidelity of their provider, they can go ahead and start to bill services. So while the county may, within limits, design its provider selection process and policy and procedures, the county must maintain strict fidelity, again, with Title 22, the drug Medi-Cal and AOD standards, the DHCS application, and I would add in there, and not only Title 22, but as Title 22 and the standards, as sometimes modified in certain areas with the waiver. Keeping all of these in mind, counties will not use their own additional standards to certify a program. You can have your standards in terms of selections, but when it comes to certifying, that is strictly along the straight lines with Title 22 and the drug Medi-Cal AOD standards and the accurate completion of and acceptance of the application. No variance there, no county ability to use your own. What if a program is not selected? There's denials and appeals. Well, county certainly, and I have in here a quote, each county must ensure that all required services are covered, so you have an incentive to find a strong and adequate provider base. However, you can deny programs. The waiver doesn't say what the list of items you may use to deny a program. Certainly, nothing that would fall over into that discrimination category. Oh, well, we had enough, let's say we had enough for-profits and we really want to have a nonprofit do this. That would not be an acceptable reason. But you do have to have, at least if you do denials, you have to have in your policies and procedures about selection a process that you will hear an appeal if someone's not selected. And within that appeal process is the ability for them to go all the way up to DHCS and have a hearing. So this appeals process needs to be in your policies and procedures. Kind of my final slide on here, but other county responsibilities, they do fit with the selection processes to have a quality improvement plan. And this goes into the county's responsibilities to monitor service delivery and having a committee that functions to evaluate quality improvement issues, and a utilization management program, which can probably use the same committee to make sure that people are accessing services quickly and efficiently moving through these levels of care. It probably fits right in with your responsibilities to, at least if you don't provide case management, to then provide oversight over the use of that. That pretty well, I would say, moves into questions. And
okay, and so we have time for these questions. So that's great. Let's go on then. Can residential services at the lowest level be considered sober living only with intensive outpatient services provided in another building? Can both be provided on the same roof? Would the number of beds be limited to 16?
Well, one of the things the waiver does is it eliminates the IMD 16-bed limitation. So that's a good thing. Now, whenever we talk about the recovery, what is it she was talking about, like a sober living facility, recovery facility. Yeah, those are an option to be covered under the IMD, or excuse me, under the waiver. Counties aren't required to provide in their package recovery residence. Now, if a program has a recovery residence, this follows under, again, not drug Medi-Cal, but under Title IX AOD standards. If you have a recovery house and your clients certainly who live there in a recovery residence can go to an intensive outpatient or an outpatient, let's say that's remote at a different site. But if you're requiring them as a requirement of living in that residence to go to this program, then you are really de facto a residential treatment facility and you need to be licensed. Certainly if you're providing any of these counseling services in the recovery residence, then you are in fact a residential treatment. So in any of those two cases, you would not be a recovery residence within an IOP. You're a residential facility, and you need to get licensed, and you need to get certified, and then you can get drug Medi-Cal certified under this county and waiver process and be part of the system of care. But outside of that, no. The waiver does not. Yeah.
Oh, I'm sorry.
No, go ahead.
What is a PED? Sorry, what is a PED?
PED is PED, excuse me, I shouldn't have put just an acronym out there. Provider Enrollment Division. That is the department at DHCS. There are two areas. One is a licensing and certification, and that does the licensing and certification, accepting applications, approving them, reviewing, doing site visits for alcohol and drug treatment programs outside of drug Medi-Cal that are just becoming licensed. Every residential facility in the state of California provides alcohol and drug services are required to be licensed under Title IX. That department does those. Additionally, they could be certified, and outpatient, intensive outpatient, and outpatient drug-free can also optionally be certified. That's the department that does those. When it's drug Medi-Cal certification, and that would be of an outpatient or residential facility, then that goes under Provider Enrollment Division. So PED is the Provider Enrollment Division. That's the division that will still, even with this modification, that will review the county recommendations for certification, and they will also review the drug Medi-Cal disclosures, and they will provide the final acceptance and acceptance and status of the provider as a drug Medi-Cal provider.
Okay, we have for OTPs currently applying for drug Medi-Cal certification, would we need to use the updated DHCS 6001 form revised on 12/14? I cannot find it online where it's not in draft form.
That's because it's still in draft form and it's not accepted. So if you're applying right now, use the old one.
Okay, I'm going to skip down.
I think it's the 1013 or 1014 revision. But you use the current, not draft.
Sorry.
Yep.
There's another form question, so I'm going to skip to that one. Repeat who is responsible for 6207 and 6210?
That would be the provider enrollment division, not the. There is a draft that's coming that's a 6209 that's supplemental changes forms, but those should go to provider enrollment as we understand it right now.
And someone else said the new provider application form is form 6002, and they screamed it out.
Well, 6002 is the application form, again, not for regular AO, and I'm going to use the term AOD, out on drug certification, not drug Medi-Cal. Drug Medi-Cal is 6001. For certification for a program that's just to the AOD standards is 6002. And that is a new form, and that is in effect and is being used.
Another form question. The new 6001 1114 form is created by Licensing and Certification Division. Does PED honor this form?
Yes. Wait, the new, let me get this right. The new 6001, repeat the question for me.
The new 6001 form is created by Licensing and Certification Division. Does PED honor this form?
The new 6001 is yes, it is. Well, it is the drug Medi-Cal certification form. So that's the one PED honors.
Okay. I think that's it on the form questions. So let me go back to where we were. Okay, so will administrative responsibilities such as recertification and audits be transferred from DHCS to county where the county is capable and interested?
I don't know why I'm getting it cut out from you. So the administrative.
Oh, I'll say that again. Will administrative responsibilities such as recertification and audits be transferred to the county where the county is capable and interested?
Well, actually, recertification doesn't matter if they're interested. That is the county's responsibility to initiate, at least in that part of initiating and doing the provisional certification of programs, also goes to recertification of programs. So the county, that's by the waiver, the county's responsibility. Now, in terms of auditing, the county is responsible in the waiver for monitoring. So there's still kind of a question in terms of recoupment because it's not defined in the 1115 waiver, the responsibility and authority. See, there's an authority in Title 22 for the department, which is DHCS, to have their post-service, post-payment review teams come and audit and sometimes vis-a-vis their audit, do recoupments from programs for services that were rendered but did not feel like they met the standards in Title 22 or the regulations. The 1115 waiver clearly says it's a responsibility of programs, of counties, to monitor their programs. And that monitoring is not only to AOD standards and Title 22 regulations in terms of administration, but I would say an audit in terms of were these services, did they meet what would be post-service, post-payment review standards? A really good question, and something that should be pressed in the stakeholders, and I have not seen this come up in stakeholder meetings, is should the counties, when they do their monitoring and their audits, when they find something that, let's say, there's a service that was provided and it's an outpatient drug-free, and it was a second service in the same day, or it was a collateral and it wasn't really with family members. So it's a service that it was paid for, but it should be recouped. And it would be recouped if a state audit and monitoring came in. Should the county go ahead and do that? And would the county be empowered to do a recoupment? Again, that empowerment only goes to the department. It doesn't go to counties in Title 22 right now. So if you're going to be held as a county to not only authorizing the services, you're going to be held to monitoring to fidelity of, again, the waiver and drug Medi-Cal and all drug Medi-Cal standards. Should you also be empowered then to make recoupments so you can manage your money well? Let's see, it's going to be an interesting process. And I think some of that, where it's hung up right now, is the whole payment method with net neutrality and looking at maybe doing, maybe per member per month type of funding rather than fee for service. That's still in the planning and development stage with DHCS. So I think some of the questions about managing that money will be revealed later, and the implications to who not only gets the responsibility but the authority. But monitoring is clearly a county mandate in the 1115 waiver, and auditing is of fiscal and provision of services clearly a part of the monitoring.
Okay. There's still quite a few questions, so let's see. On the protocols, may the county require it anyway?
You what?
It says on the protocols, may the county require it anyway?
Well, here's how the protocol, which is, again, been a standard part of the application process. And there was a management section and there was a program section. And it literally, the protocol brought down the program who was applying would present some of their policies and procedures that demonstrated, at least at a policy and procedure level, that their policies and procedures were in compliance with certain sections of the AOD standards and certain sections, maybe both, of Title 22 and the drug Medi-Cal standards. So let's say you pull that out. Well, okay, so it's not in the application. However, clearly a part of the process that's mandated is that the counties will not only review the application, but they will go do a site visit. I would say if you're a county who's saying you're looking for providers that are going to be qualified drug Medi-Cal providers, and you don't take those items that are on the protocol and at your site visit review those and approve them, then I don't know how you're recognizing that a provider meets AOD standards and drug Medi-Cal and Title 22 standards. You have to. If I were going to be a person in a county that was going to do that, I'd have my clear list, just like, in fact, I'd make this is another thing you could TA for, a clear list of what I want the provider to show to me when I go do my site visit, and I'd want it laid out on a table specifically. I don't want somebody. One of the things when at PED, the provider enrollment, when a provider would put their drug protocol in with their application, frequently what was a rejection item is, let's say in terms of part of it is personnel, policies, and procedures. And it's sections of the policy and procedure manual. And we'd have a provider send to PED their whole personnel manual or their whole fiscal manual. And I had people up there who were monitoring and certifying programs saying, I'm not going to go through your whole manual just looking for what I want. I'm telling you what I want, and you show it to me. So when if counties don't get a really, I'd say, clear and aggressive kind of role in what they're going to look for in these policies and procedures that would be a part of a protocol when they go to programs, and demand the program, put it in a very clear and discoverable manner for them so you can walk in and look at it, rather than just, hey, here's our operations manual. You're going to be spending an inordinate amount of time. It's going to be extremely difficult for you to certify these programs. But it's not going to be through the protocol that was in the application. It'll be at your site visit.
Okay. I'd say maybe there are 10 or 12 more questions to go. Let's see. Currently, there is a requirement in the DMC application to submit admitting protocols to a general acute facility. Will this still be a requirement under the waiver?
No, well, because it's the application, and the application changed in that area.
Okay.
Again, it'll be incumbent on programs to have those things, but it just won't be in the formal application. It'll be at the site visit.
Okay. Are case management and recovery management different for all?
Oh yeah, recovery management and case management are very different. Case management, again, you have, if you Google up or you look or you pull books on case management, there's various intensities. Aggressive, community case management has been used in really well with mental health. That's one model, and there are various models of case management. They're not defining that, but case management is really about connecting people to services in the community that will further and coordinating those services, and sometimes assisting them in accessing those services. That's really case management. When you look at recovery services are the ones for continuous recovery management. Well, what does that mean? Well, I think probably in 1957, we kind of woke up and said that substance use disorders are a chronic condition, and yet what's happened is we continue to treat them in acute manners, meaning that, by acute manners, I'll be admitted to a program, you open my file, you do a whole assessment, and blah, 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 and I get my treatment, and then you discharge me. Certainly I would get aftercare recommendations, and some programs even have aftercare groups. And I continue my recovery by going out in the community. But my episode is really, let's say, discrete and almost like it's acute. If I have problems, let's say even 2 weeks later, and I come back and I said, I need some outpatient treatment, you open me again, you do another assessment, and it's like, oh my God, any treatment program has just scratched their heads on that kind of thing. It's really difficult. A continuous model of recovery and recovery services say, we're going to keep as if we had, like at your doctor's office when you go in and you open your medical record, we're going to keep continuous services going on. We don't have to reopen you all the time to be able to talk to you and see you. Well, how do they do that? They do that, let's say, with telehealth recovery monitoring. So they may say, okay, we're going to follow you for 6 months or a year, and we're going to call you every couple of weeks and just say, how's it going? Are you keeping up with your aftercare plan? The recovery maintenance person, or the recovery maintenance person, somebody who contacts them, may not do case management per se, but may, in fact, talk to somebody about how do you access your case management a little better. They try and provide ongoing recovery support. They may do recovery groups for individuals in recovery or family that are in not outpatient services, but certainly an aggressive aftercare. So there are various models, and I would encourage anyone who wants to know about recovery services to, again, look up White or McClellan and Google recovery maintenance or continued recovery services. You'll find a rich array of what are described, and this is at a federal level that's going down states, about what supports an ongoing program recovery. It can look a little bit like case management, but it's actually supposed to be more of like a monitoring, mentoring support for the individual.
Yeah, I've got a couple more case management ones that I can see right now. There might be more later, but let's stay with the case management theme. What type of certifications do case managers need to have? Example, are they certified, registered, or BA degree? And the other one is there discussion about reimbursement for case management services?
Well, okay, first in terms of the qualifications, and it's not defined clearly, although anything less than a certified AOD counselor will not be. It just doesn't seem like it's. I say it doesn't seem like it's going to be reimbursable. It would be hard to say how does a person qualify if they're not even don't have the training, and even somebody who's an AOD counselor doesn't have some type of educational units that say you're not only credentialed, you're privileged to be able to do the activity. That you're going to try and shoehorn people in that don't have any credentialing, and even if they're credentialed, don't have any type of an education or experience background that says this is why they should not only be by their education but by their experience privileged to be able to do it. I think you're walking yourself out on a narrow plank. So the straight-faced and common sense would say, of course, I'm going to have people that need to be qualified in some way. The waiver is not mandating right now that case managers, in their language about it, have to be licensed people or that have to be social work specific. However, if I were looking, and again, in my program selection part, and I'm saying Title 22 doesn't tell me, the waiver's not telling me who's going to be qualified, start looking for, when you look at case management, what are the qualifications for somebody who's going to be a case manager? And you can look in mental health, that's going to tell you, and again, it just, I guess I'd say if I want somebody to case manage my kid or the thing, who do you want? But use good industry standards, because the waiver's not telling you specifically right now. Safety would say you go to good industry standards. And the other question on that was about payment. And again, we're looking in the payment section of this and the net neutrality. And net neutrality really just means that this waiver by law can't cost the federal government any more than the state's Medicaid standard program right now. So net neutrality says, in a way, more money might come in interesting ways, because we can, through a waiver, we can use money and get match in creative ways that we couldn't before. So we can provide new services and continuity of care that were not possible before. However, net neutrality says we have to use this money in a way that doesn't cost the feds anymore. And one of the ways of looking at this has been through, like, let's say, a per member per month. So there's like a flat rate. Well, what does that say to individual providers? How that pie going to be cut up? I do a part of a service for patient A, and treatment facility over there does some services for patient A, and C does services for patient A, all in 1 month. Do we split that money? How do we split that money? These are financing questions that have not been defined yet, but this does not look like it's going to be an exact fee-for-service model. And certainly anybody, as I start to talk about this, can kind of say, ooh, you can see how benefits going to come from utilizing services in a way that were not traditional, moving people through expensive. The view will be to how do we reduce people through continuity of care and more immediate access and a richer provision of a continuity of care. How do we keep people limited from those expensive levels of care? And this is where this model comes in. Again, in the primary care, this type of model says we're looking at case management, recovery maintenance, because we want to reduce what? ER visits and hospital stays. Because this waiver is larger than just the drug Medi-Cal, we're a part of that picture. But we need to be a part of that picture to say, well, we might be doing variable length of stay. If you're certifying a program that says, we do, this may be in your standards, you say when you select the program. Well, I have a program, but all of my people come in my program do 90-day treatment. No variable. That may not be in your patient selection. You say, I'm not going to put everybody in there for 90 days. We're going to do utilization review and evaluate in 30 days whether they meet ASAM discharge criteria, and then we want to move them to a lower level of care. And if you can't do that as a provider, you're not in our selection pool, because we need to manage our money. This is a huge consideration in this whole waiver endeavor.
Okay, I think we're back again to some physician questions. I'll try to see if I can join some of them. Medical consultation. Will the county contract directly with physician providers so as to comply with corporate practice of medicine restraints under California law? That's one. Another one is... Yes. Well, go ahead, answer that one.
Yes.
Okay, great.
Yeah.
Does a PsyD work for this director requirement or only an MD?
Medical director, only MD.
Okay.
In fact, not even PA. For medical director, not even PA or licensed nurse practitioner. You have to have all drug Medi-Cal under Medicaid, Medicare laws need to be under the direction of a physician, and that is a licensed MD. They can contract out and have some physical exams done by a PA or a vet.
So this one says, based on my, this is directly related to what you just said. Based on my reading of the waiver, a licensed psychologist will be able to do what a licensed MD currently must do. If Title 22 continues to require a medical director, what will this person be doing? It is presumed most providers will go with a significantly cheaper licensed person. Are we still then paying an MD to just be listed as medical director?
Well, you will. Yeah, and you're right. There's an expansion in terms. Here's the expansion in terms of doing that diagnosis and the diagnosis and the establishing medical necessity in terms of is there impairment. Again, if you look at what is medical necessity, you have a diagnosable DSM disorder. Right now under 3R or 4, you have impairments, and those impairments should respond to treatment. That's pretty well medical necessity. And certainly that was by the Title 22 emergency regs. Established the physician needed to do that. There is a proposal to change that section of Title 22 regulations. Again, for non-waiver counties, that also says besides a physician doing that part, evaluating the patient for that diagnosis and medical necessity, that in fact a licensed health practitioner, and that could be a licensed psychologist, an MFT, an LCSW, and an LCC. So there's an expansion to being able to do that component. And it looks like in the waiver, there's an expansion to be able to do that component. However, that does not relieve a program of having the at least provision of or the direction of treatment under a licensed physician. So you don't get relief from that.
Last related question to...
That means signing treatment plans. That means reviewing you still have to do a physical exam, and a physician needs to review that. You don't get relief from that one by the waiver.
Okay. Last question related to that is, can the medical director be a DO instead of an MD?
Be a what?
I guess DO, osteopathic doctor? DO?
I believe that's under the licensing. I may have to look that one up, but there's a real, I don't have it right in front of me. It's very clear in the Title 22, and that's where I would go through Title 22 of who's a qualifying, what board do they have to be licensed under. I don't have that right on my fingertips right now, and it's not hitting my mind, but all you have to do is go to Title 22 and say who's the, who's a qualifying physician, and I believe a DO might be in there.
Okay, so we're coming up on 11:30. I think what we can do is, I know some people have to go, so I think if you ask the question and you want to, and you have time and you're willing to hold on as we answer the other questions, that might be a way.
I would, for people who are still on, I want to emphasize that getting some I don't know if it's exact templates, but some good guides. If you're a county who's going to say, wow, we're not only going to have to review these applications. Again, I expect this draft application that's simpler, 6001, to come through, and by the time the waiver gets enacted, this should be in place. But still, the idea if I had to go out and review a program, do a site visit, and not only look at the facility in terms of its safety and the quality of the facility, the building, and the guts of it itself, that's one thing. But to review policies and procedures that make sure they align with, again, AOD standards and drug Medi-Cal and Title 22, and having a good guide to do that, I think it's going to be a really good tool. And I would encourage counties to say, certainly at our own level and county level, we may want to tweak that tool ourselves. But to say that every county in the state of California go for waiver needs to invent the wheel, I don't think we have to do that. I hope we, and through CIVHS, that we can figure a way to be of assistance to counties to be able to build good monitoring tools for that. We have some that we've been using to do technical assistance with just providers who are trying to apply as a front line to assist them to get their applications accepted at the Provider Enrollment Division of DACS. And I think that's a really good tool that counties could get, and we should be able to share that. I hope we can do that.
Okay, well, I think that's it. We'll see what we can do with the remaining questions, how we can answer them. Certainly, people can follow up with you directly as well. Do you have your contact information on the next slide, or shall we just give that out?
Well, no, thanks for participation, but it is through the website, the CIVHS.org, and I believe there's a method to go and request technical assistance, and it's a very easy request form. And we respond generally within 7 days.
Okay, perfect. So that would be my recommendation. People wanting continued assistance to avail themselves of the technical assistance that we have available around certification. So I want to thank Jan for your time and your presentation and sharing this information. And I want to thank everyone else for their patience as we try to not only cover the information but address your questions. We've had a large audience of over almost 200 people, so There's a lot of interest, and we do want you to know that we have technical assistance available, so feel free to contact us for that technical assistance. And thank you for your time. Jen, anything else you wanted to say? Last words to close?
I've probably talked enough. I'll answer a few more questions. But I do encourage, again, looking for that technical assistance. It's been traditionally for people who are applying. But as you look at accounting, say, we're going to have to be part of this application process, and we want to know more about what the consultants who have been assisting people to do their applications and to be successful. We're all on that resource. I really encourage it if you feel like you need some assistance.
Okay, well, thank you all for your participation. And please remember to complete the evaluation when you're done, so we can use that to inform future work. So thank you all. Take care.